Good evening, everybody. Today we are continuing with our August Awareness Month and our activities at SMA. We are absolutely delighted to have a guest speaker today, Mariachristina Scotta from Great Ormond Street Hospital for Children. Mariachristina is an exceptionally knowledgeable person, and probably, and most importantly, one of the most compassionate and kindest clinicians I have ever come across. And I'm very proud to work with Mariachristina, and I'm very glad that she's my daughter's consultant. So today, Mariachristina is going to talk about some updates about what's happening with the treatment, and at the end of this webinar, if you have any questions, please post them below the video and I will ask them if we have a chance. Over to you, Mariachristina.
Thank you very much. Thank you for the introduction, the kind words. I'm going to share my slides in a second. And I hope this would be easy to see.
Looks lovely.
Okay, so I always like to present this slide, this job, this publication of almost 10 years ago, because I think it reflects very, very nicely what was the timeline from when the SMA was first described in 1891 till when, just in 2000, the first mouse model started to be used in laboratory studies. And you can think that it took like almost 100 years, actually more than 100 years, to get from the first description of a disease when we understood what was going on in the condition, and there were the first experiments to try to find a treatment. But actually, what is very interesting is that this is a kind of a better story than many other neuromuscular, very rare condition, because at the end of these studies, we have not only one, but two pharmaceutical compound, two drugs that are actually available for patients now, and they have been approved by FDA, and one more recently by EMA as well. And if we look at the drug pipeline that I took from the website of Cure SMA, so this is not my original picture, of course, it's very interesting to see how the scenario of all the potential treatment currently for spinal muscular atrophy is evolving and is expanding year after year, with two medications now available for patients, although not everywhere, and I will expand a little bit on that. There are a number of other compounds that are currently trialed, and they are already in humans trial, and a number of furthermore compounds that are currently trialed in, not trialed, but experimented in a laboratory level. And if we think about spinal muscular atrophy, I'm not going to tell again what is spinal muscular atrophy and what is the problem or what is the defect in spinal muscular atrophy. But if we think that at the end, what happened is that because of a genetic mutation, there is a lack of SMN protein. This is what happened as a result of the genetic mutation. We know that there is, if you like, a similar gene, the SMN2 gene, which can produce only 10% of the protein. And we know that as a result of the genetic mutation, the lack of protein, what are the tissue or the organs that are suffering the most are the motor neuron and the muscle at the end, which will be weaker and hypotrophic. So the potential treatment would be, first, the attention went into how we could make the second gene that produce only 10% of the protein, the SMN2 gene, to produce a little bit more. And we now know that there are a number of drugs that are called alternative splicing modifier, that one of them, Spinraza, is already available for patients. Another one is currently in clinical trials. Or being SMA disorder or a congenital condition that is due to one single mutation, a single gene, which is the SMN1 gene, the other more, if you like, rational approach would be to put the gene back to produce again the protein. But as I said, the result of the lack of protein is that the muscle ultimately are the ones that are suffering the most. So there are a number of other approaches that are protein independent, then try to preserve the motor neuron and the muscle independently from the quantity of protein that patients have, or the quantity of protein that we are able to restore. So I will go first talking a little bit about the SMN protein independent therapeutic approaches. And there is one compound that is currently trialed by Cytokinetic Astellas. And this compound activate a specific complex, which is the troponin complex that is fundamental for the muscle contractures. And if you go into the YouTube video, you will see very nicely how the fibers, if you like, slide towards each other for the contractures. This activator might increase the force of the muscle contracture, and this could be a very important and beneficial benefit for the patients that have experiencing fatigue. And this is why most of the patients that are recruited in this study are those who are less severe, SMA type 2, 3, and 4, and a slightly older patients. And the interesting thing is that it was announced by Cytokinetic that this compound was granted orphan medicinal product designation last year. So this means that might have a faster track for the EMA approval. Another compound that is again on a clinical trial and is recruiting patients in US, Italy, and Spain. I think the recruitment is just completed, if I'm not wrong, and we were not participating in this study. Is another compound that works stopping the myostatin. Myostatin is a normal, if you like, protein or is part of the normal development of muscle. So if you block the myostatin, you might improve or increase the caliber of your muscle fiber. So the way the muscle fiber grow. So there is some speculation, and it's been used in other conditions as well, that if you block this myostatin pattern, you might improve the way the muscle fiber can grow. This drug can be administered intravenously every 4 weeks. And again, this type of drug might be, because it's not a genetic modifier, could be perhaps an ad hoc treatment that could be used on top of genetic modifier. And the patients that have been currently targeted in the trial are, again, the less severe spectrum of the disease, SMA type 2 and 3. Another thing that is coming up in the research about spinal muscular atrophy is that there is the lack of SMN protein might affect the neuromuscular junction, which is that portion that basically function as a bridge between the nerve and the muscle. So it's possible that because of the lack of the SMN protein, also the neuromuscular junction doesn't work well as it should, and the signal from the nerves to the muscle is not perfectly transmitted. The way to try to overcome that is using some drugs that have been used in other conditions that are primarily affecting the neuromuscular junction, like, for example, myasthenia. And this specific compound is a compound that is similar to what is used in myasthenia. This trial is currently running in one single site. And again, it's targeting the less severe patients. And the idea is that using this drug might reduce fatigue, which is, again, something that we are starting to study and understand a bit better in SMA type 3. If we go into the more attractive treatments, of course, those are the treatments that might improve the SMN protein level. And the rationale, of course, is that once you have the SMN protein, the motor neuron can survive or start working again if they are not death at the moment. And there might be also the potential that having restored the SMN protein might help also other organs, might have other peripheral function. The first drug that probably you already know, or if you don't know, you heard about, is Spinraza. And Spinraza is what is called an antisense oligonucleotide. This big family of drug, antisense oligonucleotide, are basically some specific genetic molecule, very small genetic molecule that are very clever, and they recognize a specific part in the SMN2 gene, which is the promoter of the exon 7 inclusion. So it's like a patch. Thanks to this patch, the exon 7 is included in the production of the SMN protein more than 10% of the times. And at the end, you will have a much higher level of functional protein. The problem or the difficulty with this compound is that this specific antisense oligonucleotide, to get into the brain and the motor neuron, needs to be administered intrathecally, because they cannot pass what is called the blood-brain barrier, which is a defense that we have normally to defend our brain, and which is a very important part of our body from toxins or from bacteria or viruses. So this specific antisense oligonucleotide cannot pass the blood-brain barrier. So they needs to be administered intrathecally. And the administration needs to be repetitive over time to make sure that the level of the drug is always effective. As you know, this drug is not fully approved, is under what we call a Mariachristina agreement, which is a 5-year agreement between the company, NHS England, and us as clinicians. So we provide the drug, and the patients that are recruitable for this Mariachristina agreement in this country, SMA type 1, 2, 3, pre-symptomatic patients, and the type 3 patients who either are ambulant or they lost ambulation within 1 year prior to the Mariachristina agreement announcement. And we as clinicians, we are supposed, or we are obliged to collect as much as possible information about benefit and about also side effects and safety of this drug. And this will be reappraised in few years' time to understand what will be the cost effectiveness of providing this drug to this population. And to give just a little bit of information on what is happening from a clinical trial point of view, because although this is an approved drug in many countries, there are still some trials that are ongoing. The drug was trialed in pre-symptomatic patients, was trialed in SMA type 1, was trialed in SMA type 2. And the pre-symptomatic patient, this is a very old slide from the first interim analysis, but what it shows that basically children treated in the first 6 weeks of life, so these were either siblings of patients who already had an established diagnosis of SMA, or in countries where, for example, there is newborn screening or there is the possibility to do that. If they were treated in the first 6 weeks of life, the way they were progressing in their milestones was better compared to patients treated a little bit late when the disease is already symptomatic, so where patients already show symptoms of weakness. And in particular, those who had 3 SMN2 copies, so those who could produce even more protein, were those who were doing better from a motor milestones point of view. And very recently, there has been a publication on this specific study and the use of nusinersen in pre-symptomatic patients. And although these pictures might not be very intuitive as soon as people look at them, what they show is that basically the patients with the SMN2 copies, they achieved, and the SMN3 copies, they all achieved the ability to sit without support, but the patients with only 2 copies, they might have achieved this ability slightly later compared to the patient with 3 copies. So they achieved this ability basically virtually in the same time frame where a child without SMA would achieve this ability. And the same happened in other more advanced motor milestones like standing alone or walking alone. Again, those who had 2 copies of SMN2 protein, SMN2 gene, they could achieve this, but many of those patients slightly later than what expected compared to those who have 3 copies, so more production of protein. So again, they achieve this ability, again, in what we consider to be the normal milestones for a child without spinal muscular atrophy. And another publication which is interesting, because there have been no clinical trials conducted in SMA type 3, so we have more anecdotal information on what is the effect of nusinersen in SMA type 3, there is interesting data showing that there is maintenance in these patients of the gross motor function, and there is also maintenance of the upper limb function. And in those who are ambulant, there is also some, if you like, improvement in what we call the 6-minute walk test. So the number of meters that a child or a patient can walk in 6 meters. So these are all very encouraging information in terms of reflecting the fact that nusinersen is very likely an effective treatment over the big spectrum of the disease, not only the severe spectrum, but also the milder spectrum of the disease. And the current scenario in terms of clinical trial is, apart from the nurture study, which is the pre-symptomatic study that is still ongoing in a long open label fashion, there is the SHINE study that has included the patients with SMA type 1 and 2 who were in the original Endear and Cherish study, which is also ongoing. There will be, actually the study already started in US, the DEVOTE study is a study to look at the possibility of increasing the amount of drug that is administered in patients, and to see whether an higher dose of drug and perhaps one less administration during the loading phase could have the same effect of the current 12 milligrams that are administered every time, or even a higher, a better effect. So there are, the EU sites are starting, or were about to start just before the lockdown. In Gauche, we will be participating in this study, and we expect, hopefully, if there won't be any other COVID-related disasters, to start early next year. And another very recent announcement was about the potential response study. This study will recruit patients who have already received another treatment. In particular, this is the gene therapy, so very young patients. And after receiving gene therapy, they will be treated with nusinersen. This is to see whether there is a lot of interest and curiosity in understanding whether combined treatment can have an additional effect, an additional benefit. And the reality is that we don't know. We don't know for sure. We don't know if it's necessary. We don't know if it's dangerous. We don't know if excessive protein might cause any problem. The reality is that we don't know. We don't have the answer to that. So the right route is to make a trial out of it and collect formal information. I think that Biogen is planning to submit the study protocol to regulatory authorities maybe by the end of this year or something like that. So there might be some protocol defined early next year. And if we go into the gene treatment, which is also very, actually, sorry, before going to the gene treatment, I just want to spend 1 or 2 slides on another compound that is also SMN2 gene splice modifier, but is a small molecule. It's not an antisense oligonucleotide, and this molecule is available orally. So this small molecule can pass the blood-brain barrier effectively, so can recognize the SMN2 gene, and basically does the same job that nusinersen does, so makes the exon 7 to be included and to produce the protein. There are a number of trials currently running for pre-symptomatic patients, the Rainbow study, Rainbow fish, they're all the fish studies, the 5 fish in SMA type 1, sunfish in SMA type 2, and non-ambulant SMA type 3, and the jewel fish, which is like a bit of a big pot, recruiting patients who either received gene therapy or nusinersen, or patients who were in the previous study, which was the Oleo study using the olesoxime, which was interrupted, or patients that were in the original study that was called the moonfish, that was stopped due to some animal finding, basically at the retina level, with a previous molecule that is slightly different from this molecule. In terms of what this drug can do, I think there has been some data presented. Unfortunately, we couldn't conduct the firefish and sunfish study in London. There will be some data presented on survival of these patients. These are SMA type 1 treated before 7 months of life. Most of these patients actually treated between 4 and 7 months. So not at the beginning of the disease, they were already symptomatic, and they have a very good survival with, I think it's overlaps with what has been shown by the nusinersen trials. And in terms of motor abilities, these are trajectory of the chopping tend, the motor ability. The patients treated earlier are those who seems to respond better, but overall, all patients seems to gain points in the chopping tend. And again, this seems very similar to what we've seen in the nusinersen trial. And very recently, there has been some public announcement that in the sunfish study, the one with SMA type 2 and 3 non-ambulant, one of the main endpoint was met, and it was to gain more than 3 points in a scale that is the motor function scale. This scale is not used in UK as a typical functional scale in our assessment. It's more used probably in France, but this scale has different dimension, looking at the upper limb, at the core strength, at the standing level. So I think it was chosen because we can assess both SMA type 2 and non-ambulant SMA type 3 under the same type of measurement. And I think this is very, very interesting and promising that a drug makes some changes, some benefit also in patients that are a bit more chronic, because these were not patients of few months old. There were patients from at least 2 years old and quite older. There were also some adults included in this study. So it's very promising that you can see improvement also in this population. And again, this is we have seen improvement also in the CHERISH study using nusinersen, especially in the younger patient. So it seems that the two drugs could be quite overlapping in terms of efficacy, although we don't have the final publication from the trial, and the trial is still ongoing. And recently Roche announced that the risdiplam is the name of the compound, can use in SMA type 1 under compassionate use in case these patients cannot be receiving nusinersen due to risk benefit. And during the COVID, there was the announcement that also if SMA type 2 were interrupted, if the treatment with nusinersen was interrupted in SMA type 2 due to COVID again, like services could not provide the lumbar punctures anymore, theaters not available, etc., one could request a compassionate use of risdiplam also for SMA type 2. But that is definitely just COVID related. I think that this might change with time, especially if the compound gets approval, EMA approval. There might be some changes in the way they will open up either compassionate use or expanded access program. Is something we still don't know, but we are all quite curious to see what will happen with time. And there is another small molecule that works in the same way, but this has been developed by Novartis. And the compound is branaplam, that has been tried only in SMA type 1. There was the original plan to trial this compound also in SMA type 2 and 3, but this has not been moved forward. And if we go to the other interesting, exciting compound, last but not the least, is the gene therapy approach. And again, this is also a very beautiful story, if you like, from a medical point of view, because it took quite short amount of time from the first laboratory results in mouse model, when after a single intravenous injection of this, if you like, adeno-associated virus that is used as a vector to bring the SMN1 gene, there was protein that could be detected at the brain level. So again, intravenous injection, but able to pass the blood-brain barrier and produce the protein. And you will probably be aware, and you read about it, or some of you participate in the original trial that was conducted in US. There were 2 cohorts of patients. The first cohort was received a lower viral loading dose, and the second cohort received a higher viral loading dose. And these patients were all SMA type 1, genetically confirmed. Again, they were treated in the first 6 months of life. And one thing that was important in terms of inclusion and exclusion criteria is that this patient didn't have already antibodies against the viral vector, because the associated adenovirus are quite common in the environment. So people might have been in contact with this virus and develop already antibodies. The particular associated adenovirus that was used for this study is the serotype 9. And this is because this serotype has a specific tropism for the motor neuron cells, so to make sure that they target the right place. And this type of virus seems to not create a disease in humans, and has a very high capacity to transduce in the cells once it's been administered, so to produce the protein. And again, the results that have been published are that the survival was definitely beyond what is the expected survival in SMA type 1. And not only these patients were surviving, they were also event-free, which means they didn't need permanent ventilation. And from a motor point of view, these are the 3 patients treated in the first cohort, so the lower level of viral vector. And these are the patients treated in the second cohort. We can see that they all make some improvement, but clearly those who were treated with the higher level and those who were treated earlier, again, seems to make more improvement in to score better, at least in the CHOP intent, so in the scale that was used for this study. And another publication came after the study was completed, and is more probably looking at potential indicators of quality of life. And in particular, there was some information about bulbar function and the ability to be fed by mouth at the end of the study. And you can see that almost half of these patients were exclusively fed by mouth at the end of the study. And another important factor was the number of hospital admission and the days in the hospital. And at the end of the study, so for a prolonged amount of time, 0% of patients that were in the gene therapy trial were hospitalized for more than 20% of the year, 20% of days of the year, compared to a much higher proportion of those patients that were in the placebo arm of the initial nusinersen study, which was the India study. And I think that these two things, the ability to preserve a good bulbar function and to be fed orally and to not be admitted so many times in the hospital over a year, are the good indicators of probably improved quality of life. So these data were very promising in this original cohort. One single injection can target the central nervous system, but also because it's intravenous, it's supposed to go everywhere. So my target also the peripheral nervous system. The problems or the difficulties that you might encounter with the gene therapy is that, again, if somebody has already pre-existing antibodies against the viral vector, so there won't be any efficacy with this drug. We don't know how long to expect this treatment to last, although it is supposed to last for many years. There were some adverse events definitely associated with this with the treatment, and they were more related to immunoresponse and some increase of some enzymes coming from the liver that are indicators of a exaggerated immunoresponse. But it seems that eventually the liver function was not compromised. And the problem is that if you get the first dose, if the effect of the first dose is not enough, or after some time goes down, you can't re-inject the same viral vector, because by then you will have antibodies and you will fight the second viral vector immediately. So there is a lot of discussion about, again, how you might retreat these patients if it's necessary. And there is lots of discussion of what is the best immunosuppression that you want to try to adopt for this patient when they receive gene therapy. This drug received FDA approval last year, most recently received EMA approval, and there is already discussion with the NHS England and NICE. And I think that there will be a formal discussion probably by the end of the year, something around October this year, and probably we might hear some deliberation about which type of patients will be eligible for this treatment around March next year. The scenario of the clinical trials is still ongoing, as happened for nusinersen, and there are still patients who are in the initial STRIVE study, which was in SMA type 1, the SPRINT study in pre-symptomatic SMA, the STRONG study currently is on hold, has been put on hold by FDA. And this is the study was using the same gene compound, if you like, the same viral vector, but instead of being administered intravenously, was administered intrathecally, so with a lumbar puncture like nusinersen. And that was meant to treat older patients, so bigger body patients, to avoid to have a much higher viral load. And what happened is that there has been some unexpected effects, not in humans, but in primates, non-human primates. So when they studied the first loading dose, there were no side effects. When in the animal models, they went to a higher dose, what happened is that the cells that are in the anterior horn of our spinal cord that are not supposed to be targeted by this gene treatment, because this gene treatment is supposed to target only the anterior horn cells, which are where there is the motor neuron. The posterior were also targeted, maybe, and there was some inflammation, and some of these cells, there was some necrosis, which means that some of the cells probably died. And the cells in this posterior part are those that are probably related with the sensation of pain. So in humans, we never observed any reduction of sensation or any reduction of the way that there is some feeling of the pain. So we don't know what is the clinical repercussion of this finding at the animal model level. But the study is currently on hold, and we are just waiting for more information to see whether it can be restarted or whether the lower dose is effective enough. So in humans, you don't need to go on to higher dose. On a positive note, there has been a very recent publication on the long-term and longitudinal observation of the patient, the SMA type 1, who were treated intravenously. And again, from a safety point of view, there has not been any finding of decreased sensation or a decreased way to feel pain. So it's a bit controversial. What is the significance of this finding in animals on a human level? But it's something that definitely needs to be studied, because I do believe it's important to consider this approach, this intrathecal approach of gene therapy, especially in bigger patients. And very recently, there has been an effort of a group of experts who has made 11 consensus statements on the use of gene therapy in spinal muscular atrophy. And this was, if you like, probably in preparation of this drug being approved and how we should follow up these patients that are treated with this drug. As I said, it's 11 statements. I just pointed out few of these statements that I found interesting. And one of the, especially towards the end, what I found interesting is that there is, at the moment, we have some very good evidence from the trials that patients that are very young and patients that have a weight that is up to 13, 14 kilos have been treated safely with this intravenous compound. There is definitely not enough information at the moment on how will be the distribution of the compound in patients that are bigger, and what is the loading level that is definitely safe. And it is important, as I said before, to keep in mind the possibility of intrathecal administration if that will be considered safe. And we still don't know, as I said before, whether two disease-modifying treatment like gene therapy and nusinersen are together are more effective than only one. And we probably, if the gene therapy will be approved in this country for patients that are older than 2 years or have a bigger weight than 13, 14 kilos, we'll probably need to have a very specific, very good structure to maintain safety for these patients, and also to, of course, look at efficacy, but first of all, to maintain a very good safety for these patients. I almost finished. I just wanted to say that since nusinersen started to be available now a few years ago, the way we approach our patients after diagnosis has changed dramatically. The way we do our consultation has changed. There is a lot of hope, and there is a lot of good coming out from this consultation, but still there are many points that will need to be addressed, and there are many other things we need to understand better. There is lots of work trying to promote newborn screening in this country to make sure that we can treat patients quite early. There is a discussion about if intrathecal administration alone is enough, or if you need any other compound to treat also from a peripheral point of view, because there is still not full understanding about any multi-organ problems that might come into these patients if you only restore the protein at the motor neuron level. And combined treatment are to be trialed to understand if they work and to understand how safe they are. And in terms of peripheral, there is a lot of work going on into animal models to look at the effect of the lack of SMN protein in other organs and tissues outside the motor neurons. And there are some small anecdotal reports also of symptoms in patients. This is something that opens different doors. We don't know where this will take us, and we definitely think that although there are now, and probably in the next couple of years, there will be more treatment available, we will have to look after our patients very carefully. We'll have to look after their safety, and we have to look for symptoms that we were not looking before. And that was my last slide, and I'm happy to take some questions if you have some.
Okay, well,
I don't know if I did it in time.
You know, it's only Wednesday evening. I think people who are interested, and they can spend extra 10-15 minutes for us. It's more, it was very interesting and informative. I definitely enjoyed it. We do have a number of questions. However, what I'm going to do is I'm going to sort of, instead of going through question by question, I'm going to kind of summarize them, make them a little bit simpler. A number of people are inquiring about how to find out about the trials, if they're eligible for the trials, and how long the trials last. So what is the best place to keep up to date with those trials, and where? So
one of the way is to attend your appointments with your neuromuscular centers. There is a network of the pediatric neuromuscular centers, and now we are expanding, including the adult centers as well, which is called SMA Reach UK. This network works in a way that consultants can refer patients for clinical trials. We send out letters to tell when clinical trials are about to start and what are the main inclusion-exclusion criteria to all the centers treating SMA patients, so the consultant will know if there is an upcoming trial. The reality is that the trial readiness is not always a possibility for every center. For example, gene therapy trial, only London and Newcastle had a gene therapy lab that could provide and administer the drug. So that was confined only in these two centers. The Jewelfish study is running in Great Ormond Street Hospital, is running in Birmingham, is running in Newcastle. So it depends on the capacity. Definitely would be ideal if we could expand the capacity for clinical trials in UK for SMA. There is an effort already done for Duchenne muscular dystrophy, the DMD hub, that works exactly to create a better trial readiness across the country. That might be something to consider also for SMA. But yeah, I think one of the things would be to attend your appointment with your consultant and they can refer. You can also inquire directly with us and probably be in touch with charities, advocacy groups. They also have newsletters all the time where you can see if there are trials coming in this country.
Thank you for that. There are other things coming out about the eligibility of MAA and how to sort of access Spinraza. So for example, somebody asks, I think I meet the eligibility criteria for Spinraza, but my consultant is refusing to assess me. I think probably the best way really to be referred to managed access oversight committee and go through the clinical panel.
Yeah, well, I mean, I don't know if I don't know why why a consultant would refuse to assess someone. I don't know. Maybe also as a advocacy groups, maybe you can help a little bit to find out with that consultant why is refusing to assess. One thing is to assess somebody and not being able to confirm that people are eligible. One thing is not wanting to assess. It means like they don't want to see the patient. It's a bit strange. So I think I would try to understand this a little bit better. There are some, unfortunately or fortunately, depends how you look at that. There are some specific criteria that needs to be followed in order to prove the effectiveness of this drug in the next 3 to 5 years. But definitely the consultant should assess you for a drug.
Okay, thank you. Another one which I also think quite interesting is about the safety. So there are a couple of questions about the safety, long-term safety of Spinraza. So somebody said, I'm eligible for treatment, but worry about the long-term side effects because obviously the treatment has been pushed through, especially in business nursing. We know that it went from here to here very quickly. And also, is there a safer way to, or easier way now to administer Spinraza as a not lumbar puncture, like a neck or some spinal cords, things like that? So if you could. So
the long-term side effects of Spinraza, there is no major indication that there will be long-term side effects of Spinraza, but it's true. It's been a trial for less than 10 years, so we don't know very much. The good thing is that because Spinraza is administered in the intrathecal space, goes only in that space and circulate there is very little leaking in the rest of the body. So the fact that Spinraza might ever affect your liver or your kidney is basically almost impossible. Not completely impossible, but almost impossible. If there is any effect on inflammatory effect, because it's in the spinal fluid, this is something we don't know yet, but there is no indication of that so far. So I would be very, very surprised. In terms of administering Spinraza, so there is a lot of discussion and there have been already some, not trials, but some devices have been used, I think in Germany and probably in US, where the device is like placed under the skin and is connected with the intrathecal space. So you just inject the drug in the device. It's like the one that is used for some chemotherapy drugs. So Biogen cannot recommend that because they never trialed that. So they don't know if a device works in the same way as a spinal lumbar puncture. The original papers published on that, they were only on safety at the moment. So they were just telling the device can be implanted, we could administer the drug, but we don't have longitudinal data in terms of efficacy. So we need to see whether the device has the same efficacy longitudinally as if you give it via the lumbar puncture. One thing that probably has been now discussed a little bit more, that devices that go into the ventricles, so high-level devices, that might not be the right thing to do. I think it should be always something to consider a bit lower down there.
Okay, thank you. And one more from the community. Somebody talking about their son is waiting for spinal fusion and also waiting for Spinraza. Now, do we delay the surgery or do we start receiving Spinraza?
So, if the son is waiting for spinal fusion, at the moment, due to COVID, lots of surgical intervention have been postponed, unless they are vital surgical intervention has been postponed. I wouldn't delay a standard of care procedure like the spinal fusion waiting for Spinraza that might not come tomorrow or in the next couple of months. So I wouldn't delay a lumbar puncture because, a spinal fusion. If you delay today, maybe then you miss your slot and you miss your train, and then it will take another year before you get the spinal fusion. There is a lot of discussion. Many consultants know already about the possibility to leave a space. And to be honest, now we are starting to do some patients with the interventional radiologist at Gauche. Between treating a very severe scoliosis and a child with spinal fusion, but with a good space left in the back, there is not so much difference. So I wouldn't delay something that might help your lung function, your digestion, your posture. I mean, not too much, but probably discuss again with the neuromuscular consultant what is their realistic time frame to start Spinraza.
Thank you. I think that's probably enough. I've got a few more, but there's yeah, I could go on and on for another hour, I think. But I appreciate that we all have lives to do, and you need to get home to your family. So we absolutely love having you here. It was very informative. We always like having a chat with you in general. I think you're very, very helpful, and thank you ever so much.
I love you. Oh, thank you. Thank you so much.
As you can hear, that one is saying she loves you.
I know, I heard. Thank you so much. Oh, I love you too, Fia.
I'm trying to say Mama.
So again, thank you for joining us today.
Oh, thank you. Thank you for asking.
And next webinar we will have on the Friday 7th. This Friday at 7 p.m. Where we're going to have Mary Bodzo talking about the amino acid diet. So I hope some of you who are listening to this one will join us later. Normally at this point, I would ask everybody to give a round of applause to our speaker. But unfortunately, since nobody can actually do it loudly, I'm going to go and go, yay! Thank you for joining us, and see you later.
Thank you very much. Have a good evening.
You too. Bye.
Bye.